I'm happy that Lynn asked me several months ago, actually, to come out and represent Mercy's Memory Clinic. Dr. Stribe is our medical director, Dr. Crane, another neurologist, sees patients in our clinic. Here at the Steps to Health seminar, there's a lot of patients out there who can really benefit from that type of a service, and we'll talk a little bit more about that a little bit later in the presentation. First of all, you know, there's normal, related to memory, there's normal aging. So where does that stop? And where does mild cognitive impairment start? And where does that stop? And where does some form of dementia start? It's some real fine lines between what's a normal aging, forgetfulness, as it starts to lead into, and we're going to talk a little bit more about mild cognitive impairment and also the various types of dementia. There's a lot of them, so I'm not going to spend a whole lot of time burdening you with a lot of details, but I will discuss them all briefly. And we'll kind of focus more on Alzheimer's disease, which is the one that you see the most and hear about the most. So first of all, dementia. You hear somebody say so-and-so has dementia or this or that. What is that exactly? Well, dementia is just a catch-all for many, many types or causes that come under the heading of dementia. And again, we're going to talk about that. So it's a general term. Dementia, the basic definition is the loss of cognitive or intellectual function impairing daily functioning. That's the basic definition of dementia. This can involve a variety of different things, memory loss, inability to use or understand language, behavioral issues, even possible hallucinations, delusions. There's a lot of signs and symptoms that a patient might display that fall under the heading of dementia. Dementia is a syndrome. A syndrome is, by definition, is a collection of signs and symptoms. Not just one thing. You can say, oh, this patient has dementia because they have this one thing going on. It's a collection of signs and symptoms that would indicate a certain pathology. A syndrome. And a syndrome may be comprised of memory loss, disorientation, et cetera, et cetera. Some other syndromes that you, I'm sure, have heard of are premenstrual syndrome. AIDS is a syndrome. Acquired immunodeficiency syndrome, that's what AIDS stands for. Premenstrual syndrome. And SARS, which is severe acute respiratory syndrome. In 2011, the criteria for diagnosing a person with dementia it's the following criteria. It has to interfere with a person's ability to function either at home or at work. The patient has to have shown a steady progressive decline over a 6 to 12 month period. Cognitive impairment derived through objective assessment and informant history during the diagnosis. You don't only want to do an assessment and hear what the patient has to say, but a real important part of doing a diagnosis for dementia is what the informant, which can be the family member, a close friend, whoever it is that really knows that patient well. But it's real important to have the informant history as well. And in order to have this dementia diagnosis, the impairment must not be able to be explained by other factors, such as an acute illness of some kind, intoxication, or a psychiatric disease. Now, I'm just briefly going to touch on the types of dementia, and we're going to talk more, as I said, about Alzheimer's disease in a few minutes. But neurodegenerative disorders, the most common one is Alzheimer's disease. about 50 to 60% of all dementia cases are Alzheimer's disease. In this case, it's a destruction of the neurons and the synapses. We just say it's the destruction of the nerves in the brain and the neurotransmitter that transmits signals within the brain. That's what causes Alzheimer's disease. Its most early symptom for Alzheimer's disease is going to be short-term memory loss. That's what you're going to see first. Long-term might come at a later point, and other things might come at a later point, such as language skills, executive functions, inability to plan or make decisions. But the first thing you'll see in Alzheimer's is short-term memory problems. As Alzheimer's spreads, then more nerve cells in the brain become damaged. The brain shrinks and it becomes less functional. The brain is an organ, just like all other organs in our body, and the brain ages, just like all the other organs in our body. But when the plaques and tangles of Alzheimer's disease affect the brain, then the brain you can actually see that on an MRI or a CAT scan. You can see the brain tissues actually shrunk. In the spaces where you'd normally see cerebrospinal fluid, the ventricles in the brain get larger because there's less brain tissue. Another type of dementia is called frontal temporal dementia. Sometimes you hear this referred to as Pick's disease. This is about 2 to 10% of all dementia patients. Now, instead of having memory problem be the issue first with these patients, you're going to see behavioral and personality problems, motor problems, impaired language and speech, and although the memory is not initially affected, it will come into the picture a little bit later in that particular illness. So that's frontal temporal dementia, and that's a totally different thing than how Alzheimer's works. There's another called dementia with Lewy bodies. This is about 5% of all dementia patients. And with this, the patient will have an abnormal protein, which is referred to as a Lewy body. And these abnormal deposits deposit themselves in the brain's cortex, creating confusion, poor judgment, hallucinations, a lot of different things. The cause of this is unknown at this point. In fact, a lot of things to do with dementias, Alzheimer's, etc., are still being studied. There's a lot of things that are unknown. There's a lot of work to be done in this whole area. Another is Parkinson's disease, which is by itself not really a form of dementia. This is a disease that affects nerve cells in the brain controlling muscle movement. It affects the nerves that produce a hormone called dopamine. But oftentimes, eventually, further down the road, some patients may develop dementia later. But initially, with Parkinson's disease, you won't see the memory problems, but that can develop a little bit later in Parkinson's disease. Another that we see quite a bit of as we're looking at MRIs and CTs in the memory clinic is vascular cognitive impairment. This is about 8% of the dementias. It's about 8% of vascular cognitive impairment. These are people who have lived long periods of time with uncontrolled high blood pressure, high cholesterol, high triglycerides. And what happens is they, unbeknownst to them, because they're asymptomatic, have small strokes in the brain. And you can actually see on an MRI the little white spots that are there. And every time you get a little white lesion or a little white spot that was caused by a small stroke, that's taking away healthy brain tissue. So vascular cognitive impairment is something that we do see fairly often. One of the big reasons for having an MRI or a CT to rule out other things, which we'll talk about a little bit later here. There are some types of dementia that also may be reversible. One of them is infection. A patient might get a meningitis or something like that. Medicine reactions can cause temporary problems with memory. Sometimes in the clinic we see patients come in with a long, long list of medications. Sometimes they've been prescribed by several different doctors. And the first thing that our physicians look at is that medication list to see what medication or what group of medications might either be reacting with each other or causing some of the dementia problems or some of the behavioral problems. So medicine is a big thing that gets looked at very quickly. Metabolic or endocrine imbalances. Another thing that we look at very quickly is thyroid function. If a thyroid is not normal, if the thyroid hormones are not normal, that can also cause something that mimics dementia. Hydrocephalus, that's, as you probably all know, a fluid buildup on the brain, or a brain tumor. Those are all things that can look like dementia, and until you take a picture, an MRI or a CAT scan to rule them out, that's one of the big reasons you do those x-rays, is to rule other things out. Then you can determine, that they don't have a brain tumor and the dementia is not caused by that, but by something else. Subdural hematomas, somebody that hits their head and has an injury, a concussion, and if you get a bleed under the dura of the brain, that's a very critical type of a injury to get taken care of very quickly, because a person can have brain damage very quickly unless you get to a neurosurgeon and get that pressure taken off. But a subdural hematoma from a blood collection under the cranium, under the dura, can mimic dementia. Heart or lung problems, and the reason this can do that is just because you're not getting enough oxygen to the brain tissue. Nutritional deficiency, another thing gets looked at very quickly is what's the level of B12. If a person's B12 level is not normal, that can also mimic dementia symptoms. Substance abuse, poisoning, stress, an increase or decrease in stimulation, and also sleep. That's another thing that we talk to patients about, is what's their sleep patterns like? Are they sleeping, through the night, or are they wandering? Are they getting good quality sleep? Do they need a CPAP or a BiPAP? Sometimes we'll have a sleep study done to find out what their oxygen saturation is at night while they're sleeping. Because if they're not getting good sleep, and when they are sleeping, they're not getting adequate oxygen, that too has an effect on how we think when we're awake. So let's talk about aging of the brain. 50 years old and plus. Once we hit 50, as much as I hate to admit this too, the number of neurons and connections between nerve cells starts to decline. That's just, no matter if we're healthy or not healthy, we start to lose neurons in our brain once we hit roughly age 50. The brain mass decreases, the brain shrinks. It's not an amount that's real noticeable to look at it on an MRI or a CAT scan, but the brain does shrink just through normal aging. There's a little bit of a decline in ability to learn new skills. In fact, if you're 50 or 55 or 60, you might find that learning to use a new TV control wasn't as easy for you as it might have been 10 years ago. It's just trying to learn new tasks might be just slightly difficult. Doesn't mean that there's a problem. It just means your brain is aging a little bit. The neurofibrillary tangles and amyloid plaques. This is one of the things I'll talk a little bit more about in a minute. This is seen in all brains of patients with Alzheimer's disease. And the little bit of scary thing in a way is that most brains 65 years old and older have some degree of what they call plaques and tangles within the brain. They're not causing any problem, they're not no symptoms or anything like that, but we start to develop those things as early as 65 years of age. Now there's a thing that the brain has called cognitive reserve. And what cognitive reserve is the brain's own resistance to dementia. It's kind of like its own way to battle it. Cognitive reserve is the mind's resilience to a neuropathological damage to the brain. And what determines what our resilience is, or what our level of cognitive reserve is determined by a person's IQ, brain size. A patient with or a person with a higher brain weight and more nerve cells would have less clinical signs of Alzheimer's disease. The level of education and the amount of physical, thinking, and social activities that a person does throughout their life. So if a person with all these things, IQ, brain size, level of education, and physical exercise, mental exercise, and socialization, that increases the brain's resistance to dementia. It's called cognitive reserve. Now, as you go from whatever normal aging of the brain is, or normal memory issues related to aging, there's another step. The next level on the continuum is called mild cognitive impairment. This is a pattern of forgetfulness beyond what you'd see in a normal aging. But the patient is still able to be independent and function just fine. But it is an escalation from normal memory issues to the next level called mild cognitive impairment. There's a couple of different types. One is called amnestic, which means amnesia or forgetfulness or memories involved. And then there's another one where memory is not involved. When a patient has MCI, or mild cognitive impairment, the risk of Alzheimer's, there's a higher risk of Alzheimer's when the memory is affected. So if you have the amnestic type of mild cognitive impairment, it doesn't mean that you will definitely develop Alzheimer's later. It just means there's a little bit higher risk that you might develop Alzheimer's. Mild cognitive impairment, so that's the next step beyond. Normal aging versus mild cognitive impairment. With normal aging, for example, you might have an occasional loss of words, or you might forget a name. With mild cognitive impairment, the memory loss is more than expected for the age of a person, and will increase, and has increased over a period of 6 to 12 months and become more noticeable. With mild cognitive impairment, you'll show decreased memory, but all other things like attention span, concentration, reasoning, judgment, all those types of things are still doing well. Those have not been affected at that point. Now, moving forward to Alzheimer's disease, which we've already said of all the dementias is about 50% at least of the dementias. There was a physician in Germany named Dr. Alois Alzheimer, and he lived from 1864 to 1915. He was a German psychiatrist and neuropathologist. And in 1906, he was doing his work, and he examined, after the death of a young 51-year-old lady who lived with severe memory loss and paranoia. He examined her brain post-mortem. And what he discovered was these plaques and tangles that I mentioned to you a few minutes ago that are found in the brains of Alzheimer's patients. So that was the first discovery by Dr. Alzheimer back in 1906 of what actually the cause is, or what a brain looks like with Alzheimer's disease. The only way that there is at this point in time to get a definitive diagnosis of Alzheimer's disease is to do an autopsy on the brain of a person that had Alzheimer's disease after they've passed away. With the techniques that we have now, you can get, be 90% sure that it is Alzheimer's disease through the various testing and things that we do, but there's no way to get that definitive answer of if a patient died of Alzheimer's disease until actually doing an autopsy on the brain. Alzheimer's disease, it's a progressive disease. It's not a disease that stops or turns back and goes in a positive direction. It's a progressive disease. It impairs memory and thinking skills, and it progresses in a bad sort of way. With Alzheimer's disease, symptoms first appear after age 60. It's very rare to see a patient that truly has Alzheimer's disease that's less than age 60. With memory loss around age 60, it's most often the diagnosis will turn out to be Alzheimer's. If a young patient of around 60 has short-term memory loss, most likely all the testing and things have to occur, but most likely that's going to be Alzheimer's disease. With older people, if they start to experience memory loss, it may be some other cause other than Alzheimer's. Younger onset with Alzheimer's disease, younger patients often show a worse progression of disease than, say, a person that contacted Alzheimer's disease at age 80 or something like that. The risk for Alzheimer's disease is 4 times higher in African Americans. It's 2 times higher in Hispanics, and the reason for that is both of those tend to have a higher rate of vascular disease, untreated vascular disease. Now, an accepted 10 warning signs, and I think this is in your handout too. Not all of my slides are in your handout, but a lot of them are. The 10 warning signs, and this is accepted by the Alzheimer's Association for Alzheimer's disease. The first is recent memory loss, such as you can't remember dates all of a sudden, or you can't remember an event, and I mean on a short-term basis, which then tends to disrupt a person's life. Secondly, a person would have difficulty in planning or problem solving. Sometimes difficulty with their money management, tracking bills, driving to a familiar place that's not so familiar anymore. They would tend to have a lower concentration level. Thirdly, difficulty with familiar tasks, such as they might have been a person, again, that did the family budget all through their life, and all of a sudden that becomes complicated for them. You might have trouble understanding the TV control that you've been using for years, or remembering how to turn the microwave on, or something like that they've been very familiar with, and this is a change. One thing I was just talking with someone before we came up here is that sometimes a person that's in the early stages of Alzheimer's disease can cope with it for quite a long period of time and kind of hide it from other people. So they might actually have been dealing with it for some period of time before it becomes noticeable to other people. Confusion with time or place. They might not be able to tell you what day of the week it is, or what city they're in, what county they're in. These are changes. These are warning signs now. Difficulty understanding visual relationships. Might have trouble reading all of a sudden, or judging distance, that type of thing. Things that are a change from what their behavior had been. Problems with spoken or written words, like trying to find the right word. Like an example I put in there is that some people may not be able to think of what this is called. It's a watch. And they might tell you, after they think about it a little bit, a hand clock, or think of some other name that does describe it, but it's not really what it's called. And also they might start to show difficulty with conversation, and actually might start to socially withdraw as a result of this. Misplacing or unable to retrace steps, putting things in very unusual places, and then not be able to remember where they put them, and then in some cases accusing their spouse or someone else of stealing their items. This happens with Alzheimer's disease throughout, but that is also one of the early things that might be kind of tip you off that there's something that's changed. Decreased or poor judgment. We sometimes hear of families tell us that their mom or their dad, every time the phone rings and somebody's collecting money, they just give money, and the kids or the caregivers don't find out about this until there's actually been a lot of money gone out. to things that probably shouldn't have. So they fall for money scams easy, and you'll notice their grooming and their cleanliness sometimes will change. Inability to choose right clothing and get dressed by themselves and those types of things. Just, again, things that kind of key us in that there's something that's changed that's going on. Again, I mentioned a minute ago withdrawal from activities. You might see, because they are struggling, and whether we realize it yet or not, they realize it, and they might start they might begin to not do some of the things that they had done, withdraw from social activities, not go to church anymore, whatever, clubs, hobbies, just that's a change that you might see. Changes in mood or personality. They might appear to be more confused or depressed, suspicious, anxious, or fearful. So those are the 10 warning signs that are pretty universally accepted for Alzheimer's disease. Alzheimer's, its onset is insidious, meaning that it's very gradual and it's not real obvious. So it can kind of sneak up on us. The course is chronic, and the symptoms will progress. As I mentioned a little while ago, once it's Alzheimer's disease, it's not going to stand still. It's going to move forward in a negative sort of way. Its progression is very slow, sometimes 10 to 14 years. It just depends on the individual. Its duration is months to years. Alertness is usually normal until you get into the later stages of Alzheimer's disease. I'm going to talk just in a couple of minutes about the stages. Their awareness is clear. Their attention is fairly normal up until the later stages of Alzheimer's. And oftentimes their orientation, though, you can tell does become impaired. Memory, the short term, is initially involved, which I mentioned. But the long-term memory eventually becomes a problem as well. But the short-term memory is the first key. Their thinking, they have difficulty with abstraction. They'll tend to show poor judgment about things. They'll have difficulty finding words. They might be emotionally apathetic, labile, irritable, and these things might sort of progress as the disease progresses. Their sleep, they might have an unusual sleep-wake cycle, and they might eventually do things like wander at night, and that creates a lot of problems potentially for the patient and definitely for the caregivers. I talked a little bit ago about Dr. Alzheimer and what he found in that 51-year-old female, the plaques and tangles that symbolize Alzheimer's disease. I think I put that in your printout there, but it basically stands for a beta amyloid plaque. It's a dense deposit of protein in the cellular material that's found outside of the nerves in the brains. And this builds up over a long period of time, over a number of years. And then the neurofibrillary tangles, these are twisted fibers that build up inside of the nerve itself. And that's also referred to as tau, T-A-U. And these tau levels change when the brain then becomes injured from the plaques and the tangles. So that's the characteristic thing about Alzheimer's disease. Now, some differences between age-related memory change and Alzheimer's. With normal age-related, you might make a bad decision once in a while. I mean, we all do that, regardless. With Alzheimer's disease, the person might show poor judgment and poor decision-making on a very regular basis. With age-related memory, you might miss a monthly payment once in a while. That can even happen to any of us. Or in Alzheimer's, a total inability to manage money. They just completely lose that ability to even put two and two together eventually. And usually someone has to take that over from the person. Age-related, you might forget what day it is, but you remember it later. With the Alzheimer's, you lose track of the day, the time, the month, And you see this when we're evaluating patients in the clinic. There's certain tests that I'll talk to you about in a couple minutes that we do, and oftentimes they're unable to tell you some of the what we would consider to be some of the simplest things. With age-related, sometimes we forget what to use and what word to use, and in Alzheimer's, they might have just total difficulty having any type of a conversation at all. With normal age-related memory, we might lose things from time to time, but we can retrace our steps and remember where we set the keys last night or whatever it is. But with Alzheimer's, when they misplace things, they can't retrace their steps or find them. I mentioned Alzheimer's staging. There are actually 7 stages that we use in the clinic, which are used universally across the world, actually, in memory clinics. 7 stages, and actually I had one in my bag I was going to hold up and show you. You wouldn't be able to read it from where you're at anyway. But there's certain tasks that we ask the patient or the caregiver if that person can do, and then we have a checklist. But in general, the first stage is minimal impairment. That might be some things like, their memory might be giving them some trouble. They might find themselves at some point, if they're still driving, and lots of times they still are in the early stages, they meant to drive to the grocery store and they ended up going to the church instead, or, just kind of getting disoriented. Second is like mild decline. You start to get into things like unable to take care of finances. They might be having difficulty actually choosing the right clothing for the day, for the season, for the occasion. As you move into mild cognitive decline, difficulty, showering themselves and trouble toileting. Stage 4 is mild cognitive decline. Stage 5, moderately severe cognitive decline. Stage 6 is severe cognitive decline. And stage 7 is very severe cognitive decline. And I could tell you all of what is associated with that if we wanted to take the time, but I don't think that's probably important to you at the moment. But I can show you that afterwards. I brought one of those forms with me. Now, medications. This is one of the things. Actually, I like it better like this. Medications. We hear about them all the time on TV. We read about them in Parade magazine. It doesn't matter if it's Alzheimer's disease medications or if it's something else. There's somebody out there always trying to sell us something. And with the medications that are associated with Alzheimer's, there are some. They don't work particularly well for a large percentage of patients. One of the categories of medications for Alzheimer's disease is called the cholinesterase inhibitors. I'm not even going to begin to try to get too in depth on that, but what it basically does is it attempts to boost nerve signals among a brain that's working with fewer neurons or nerves. It inhibits a certain enzyme from breaking down acetylcholine, which is very important neurotransmitter for transmitting signals to different compartments of the brain. So that's what that type of a medication is intended to do. That's called the cholinesterase inhibitors. Now, in that particular category of medications, a lot of people have heard of Aricept, Exelon, and galantamine. They come in varying doses. The physicians in our clinic know that these medications were probably only going to benefit about 20% of patients in the very early stages of Alzheimer's, and then they're going to stop helping. But if it's an appropriate patient, the two neurologists in our clinic, if it's an appropriate situation, they're not opposed to letting a patient try them to see if they do see some advantage. And normally what they'll do is they'll put them on a small dose, like a 5 milligram dose, for a couple of weeks, and if they don't have any side effects, they'll let them jump up to the next dose, which is 10 milligrams, and then recheck them in 2 to 3 months. Is everybody hearing me okay? Okay. If the family or the patient feels like it's being beneficial, it's given them a little bit more clarity, an ability to think a little bit more clearly, the neurologist will choose to go ahead and leave them on the medication. However, if they find that there's no benefit and perhaps there's even been side effects and they are expensive, they just as soon stop that medication. But they want to give it a chance in patients that it might be appropriate for. So the ones you're going to hear about are Aricept, Exelon, and Exelon also offers a patch which theoretically helps with side effects. It's not an oral medication, but it's a patch that you actually put on every day. The problem, again, as I mentioned, with these types of medications is there's a lot of possible side effects, mostly GI symptoms, but the most common side effects that we see are diarrhea and vivid dreams with that particular category of medications for Alzheimer's. There's another one, it's called Namenda, and works in a totally different way. It's designed for moderate to severe levels of Alzheimer's disease, and it's usually used in conjunction with one of the other medications that I mentioned, Aricept or Exelon. It's usually not used alone by itself, and it's only been shown to be beneficial in moderate to severe dementia. So the fact of the matter is, at this moment in time, there is no cure for Alzheimer's. I do know from hearing a physician named Dr. Susan Schultz speak just about 2 months ago. She's a researcher at the University of Iowa studying Alzheimer's disease, that there's a lot of irons in the fire, and there are some things that they are working on that they see might be beneficial for the future. But everything right now, as far as any cures or anything that will help Alzheimer's patients a whole lot, there's really nothing there just yet. So there is no cure. So why take a patient to a clinic to be evaluated if there's no cure? Well, there's a number of reasons why. And one of them is so that there can be an explanation of the abnormal behavior that the family or the caregivers might be seeing. It may be a treatable condition that's causing the memory loss or the dementia signs and symptoms. It may be a patient may be over-medicated. As I mentioned earlier, we find that some of the long lists of medications, that's one of the first things that our neurologist looks at to see is there something there that might be causing this behavior. It could be depression, anxiety, thyroid issues, or B12 levels that are not normal. So if you don't take the person in to get them evaluated because you know there's no cure, we might miss something. There might be something there that's very treatable, such as the things that I mentioned. It may be rooted in cardiovascular problems. I mentioned the vascular cognitive impairment, where the patient's living with high blood pressure and high cholesterol and high triglycerides, and they're creating all these small strokes in their brain. If it's rooted in those types of things, those things can be corrected. You probably can't fix some of the damage, but you can get it corrected so no more damage occurs by getting their cholesterol in line, getting on blood pressure medication going, or whatever it might take. Lifestyle changes may help. One of the big things is exercise, diet, for example, weight, socialization, working the mind, which we'll talk about a little bit more in a few minutes here. And then to identify for the patient, and more than that for the family or the caregivers, the safety issues that might be associated with a patient that's going through some early dementia. Early caregiver education, and also we, down at Mercy, we have a caregiver support group that's proving to be helpful for caregivers, and we also have a social worker and an occupational therapist as a part of our team. With screening for dementia or Alzheimer's disease, one of the first things we get is a medical and a psychiatric history, plus that informant interview that we talked about. This is going to be the caregiver, the family member, somebody that's very close to the patient. A neurological exam by the neurologist where they're going to, check reflexes and eye movements and this and that, listen to the vas carotids and do a neurological exam, and also a mental status exam. There's varying ones out there. There's 3 different ones actually that we use in our clinic. One's called the mini mental, one's called the SLUMS, which stands for some long word, and then one's called the Montreal. But those are the types of tests where you're asking a patient, what day is it, what county do we live in, who's the president, seeing if they can do a little simple subtraction, how many animals can they name, do a little memory test. It only takes about 20 minutes, but that's part of the evaluation, is doing one of the mental status exams. And then in a lot of cases, if it's appropriate, the physician might determine we need an MRI or a CAT scan to rule out a stroke, a brain tumor, something like that. So we order those things. I already mentioned thyroid levels and B12 levels. Sometimes we'll have blood tests done. Also, if a patient's living alone especially, there's something called a cognitive performance test that our occupational therapists do. And Dr. Stribe likes to refer to it as a kitchen test, but it's not just in the kitchen. It's where the patient goes in a room for about an hour with an occupational therapist and shows that they know how to make a piece of toast, shows that they know how to take a phone call, shows that they know how to take medications out of their medication box, and displays whether or not there's safety issues. It's called a cognitive performance test. And we also have a neuropsychologist on staff that sometimes, especially if it's a young patient, Dr. Stribe will go ahead, and Dr. Crane as well, have a neuropsychological examination done. Also, there's driving tests available with our occupational therapists if it becomes necessary. Driving is one of the, I've heard the neurologists say that's one of the most difficult things they have to deal with patients that are starting to have issues, is to talk to them about driving. And maybe they should restrict their driving, or maybe they shouldn't be driving at all. That's very complicated to talk to anybody about. So with memory clinic guidance, education, particularly for the caregivers, support group, dealing with safety issues like cooking. Is the patient cooking at home? Are they leaving the stove on? Are they by themselves? Is there somebody watching over them? The driving that I mentioned, are they able to be alone safely? Could they respond to an emergency if they had an emergency, if they were there by themselves? Financial issues, talking to caregivers about things like financial issues, advance directives, power of attorney, legal guardianship, and living wills and medical directives. And those things that are things that our social worker gets involved with and really has all that information, and she uses her expertise many times with our families and caregivers. Talking about caregiver issues, this becomes really big, because 70% of caregiving at this point in time is still home-based for patients with dementia and Alzheimer's disease. There's approximately 10 million unpaid caregivers in the United States, and 1/3 of the caregiving lasts quite a long period of time, at least 5 years. And sometimes it can last as long as 10 to 14 years, ranging from the beginning with home care and sometimes on to assisted and other types of care facilities. Caregiver stress, it's going to be there whether their loved one is at home with them or whether they're in an institution. There's a book that I'm going to show you in a minute. It's called The 36-Hour Day. And that's because sometimes a caregiver's day seems like a 36-hour day. Caregiver stress, there are signs of caregiver stress that a person can notice. Number one would be denial of dementia symptoms, that this is not happening with my loved one. They might withdraw socially. They might get angry and show anger in a short temper with the person with Alzheimer's disease or others over time. This continuous stress of dealing with this person, which is a loved one of theirs, with this disease, it really can take a toll over time. And they might display anxiety or depression, exhaustion, but yet be unable to sleep. And they might display irritability. Being a caregiver for these patients is very difficult and complex. As I mentioned, we do have a caregiver support group for caregivers of dementia and Alzheimer's patients here at Mercy Medical Center. They can discuss situations with each other, they can share, they can vent. It's just an opportunity to become a more confident caregiver. We have speakers like Thursday night this week. Actually, Dr. Stribe is going to speak. Every month we have just a short 15 or 20-minute presentation, and the rest of the time is for the people who come to this support group to have time to share and exchange ideas with each other. In a caregiver support group, you can be a student, you can learn from other people's experiences, you can be a mentor to others who are in need and not sure which direction to turn next, and you can be a teacher to those sharing ideas that might be of value, something that you've done at home that worked well, and you can share that with others so they have an opportunity as well. There's something that's coming down the pike. As I mentioned, Dr. Schultz from the University of Iowa, I heard her speak, and I've seen this elsewhere in the literature. It's called biomarkers. And these biomarkers are tests to determine the changes in the plaque and tangles, in the amyloid, in the tau, in alive persons, in people who are still alive. They can buy this, and this is still in a research phase only, but through cerebral spinal fluid tests like a spinal tap or blood samples, they might be able to evaluate what the amyloid and tau levels are in a person who's living. Also, brain imaging is getting much more precise and improved to detect cell injury of the brain that would show that Alzheimer's disease is present. The advantage of this would be to allow for detection before Alzheimer's symptoms are seen. And again, this is strictly in the research mode right now, but it's something that they're working on at a lot of different research facilities across the country. We've had a couple people recently ask about something that they saw somewhere. I don't know if it was in Parade magazine or on the internet or where. But it's called an intranasal insulin study. And this is a current study in 2011. Susan Clark, PhD, and her team found that they had 36 participants in this study. And they found that with a certain dosage of insulin, these patients, and you know how they have a control group, and then they had a 20 and they had a 40. But the ones that received the 20 international units of insulin showed, with Alzheimer's patients, showed displayed stabilized or improved cognition, function, and improved glucose metabolism. So that's something that was a positive result relative to insulin in Alzheimer's disease. However, their conclusion was, so we don't start jumping up and down too much, was that the results were positive, but it really requires a follow-up trial with a lot larger group to really show if that is going to be beneficial or not. But we have had some family members inquiring about the intranasal insulin study that's been done. What about family history as it relates to Alzheimer's disease? A parent, brother, or sister with Alzheimer's. If a person has a parent, brother, or sister who had Alzheimer's disease, you're going to be 2 to 3 times more likely to develop Alzheimer's if the family member developed Alzheimer's at a young age, 60 or so. If the patient didn't develop Alzheimer's disease until they were older, say like 80 or 85 years old or 90 or whatever older is, then that person would only be at the same risk as anybody else aging at that same age. So where you're going to find a risk is if it's a parent, brother, or sister, and if they got it young, then you might consider that you might have a little increased risk of developing Alzheimer's disease. So what do we do to prevent dementia or Alzheimer's disease? We tell our patients and our family this all the time, and we sure wish we could just hand them a magic pill and everything would be well, but that's not where we are right now. Physical exercise for the patient with dementia, or for those of us who don't want to be sure that we can not get dementia. Physical exercise, mental exercise, doing things like, puzzles or things that keep your brain stimulated. Socialization is real important. Those are the three things: physical exercise, mental exercise, and socialization. Live a healthy lifestyle. Eat healthy. Smoking is a no-no. Appropriate alcohol consumption. Person should think about that. Live with a sense of purpose. Have some goals and things that keep your mind stimulated as you move forward and go through life. And this is for us too. Preventative screenings with your family physician to be sure that things that you can't see that might not be doing as well as you think, things like triglycerides, cholesterol, blood pressure, blood glucose, those are things can be not normal within our bodies and asymptomatic unless we're getting a checkup once in a while. So having that family physician and getting the regular screenings for our age group that we should be getting once a year, or whatever you and your physician agree is appropriate for you, those are very important. So in summary, Alzheimer's disease is progressive. There is currently no cure, I'm sad to say. Medications are minimally helpful, although helpful to a small percentage of patients for a while. Research is ongoing, and drug trials are ongoing. Screening is helpful for family and caregivers to help to try to plan what might be helpful for the caregivers, especially like there's things called respite care. How can the caregivers get a break? There's places like Milestones where patients can go to enjoy in and amongst other patients and still take the load off of the caregivers to give them a break, like Milestones. Caregiver stress is significant, and the two resources that I just wanted to, I don't know why I left that water sit there the whole time, just teasing myself to knock it off, but I didn't knock it off yet. This is called The 36-Hour Day, and this is a book you can buy just about anywhere, and it has a lot of good information about Alzheimer's disease and caregivers and caregiver stress. The one that we recommend in our clinic, it's actually the Mayo Clinic Guide to Alzheimer's Disease, and this book is just excellent. It's very easy to understand. It's very easy to read. A lot of the information that I've discussed with you tonight has been collaborated by looking in this book. Didn't all come from this book, but this is, I know at the Mercy Gift Shop they have it. It's $29.95. I'm sure there's other places where a person can order it online or whatnot, but this is the one that we recommend, Mayo Clinic's Guide to Alzheimer's Disease. So, should I worry? I think that was part of the title that Lynn had. Is there a family history? And if there's a family history, did that family member develop Alzheimer's at a young age? That could be some reason for some degree of concern. Have you lived a healthy lifestyle, and are you living a healthy lifestyle? Have you exercised your body and your mind? And have you engaged in a social existence? Aging of the brain and memory and all those things they're going to happen to all of us at varying degrees as the organ, what we call our brain, ages. but some are going to end up with dementia or Alzheimer's, but not all of us will. But we're all going to be affected in some degree as we move forward. I know I saw a number somewhere in the last few days that by the year 2030, 19% of the population is going to be over the age of 65. So you look at that number and then look at the fact that we're living longer. So I know that, and I just saw an article on CNN.com a couple of weeks ago, there are people in important places like Washington, D.C., who understand that this is a problem and they really want to kick it and try to get some things moving forward with Alzheimer's and dementia, because as the population ages and as we live longer and longer, this problem is not going to become smaller, it's going to become a larger problem for society. So with that, hopefully there's at least some bit of information there that was of value to you. I wish, again, we could say tonight that there's a cure and we're all going to go home and live happily ever after, but that's not the message tonight. Thank you very much.